Hello to everyone.
We
can
can't
you
hear you.
me? Hello?
Yeah, we can hear you.
Okay, can I proceed? It's okay for you?
Yes, please.
Okay, so first of all, many thanks for the invitation and sorry, but we had a lot of problems with understanding the time difference. And today, Saturday, I have to do the greet ward round in the hospital, so I will be leaving in half an hour. So I am very happy to be invited by the Pakistan Society of Neurosurgeons. I have been visiting Pakistan already 3 times. I know many of you, so I'm very happy to be with you today. I thank Salman Sharif and Tariq Khan for the invitation. Now I share my screen. And, okay. If you just confirm me that you can see my screen.
Not yet, Franco.
Yeah, I wait. Now my computer says it's sharing.
Yes, we've got it.
Oh, okay, then I go. I have limited my presentation to only 12 minutes, so I don't speak about every controversies we have, but these are my disclosures. But only one controversy, it's if we do have raised intracranial pressure, we usually have to decompress the patient. Do we have alternatives to decompression, means hinge craniectomy or sternotomy? Because in the web, even in papers published, it seems that there is a large discussion about can we avoid decompression to control intracranial pressure as neurosurgeons. These are more than 5,000 cranial decompression done in Europe, and you see that most of them are related to trauma, but we also have vascular tumors and so on. So is decompression a panacea, as we say in Greek or in Latin? The panacea, it's, as you see, the panacea, it's about, you know, that's, it's about treating everything with the same technical approach. We do have in decompression at least 2 class 1 published studies. One is the DECRA study. It's a study limited to patients with diffuse injury with an ICP over 20 for more than 15 minutes who had a bilateral bifrontal decompression. And as you understand, and you see it here, the decompression produced a deep decrease in intracranial pressure, but the result, you see it here, especially concerning vegetative states and severe disability, were worse in the surgical part of the study in decompressive craniectomy. So the conclusion was that we cannot base the indication for decompression only on ICP, and that bilateral decompression does not work in diffuse injury with ICP over 20. Then we have the rescue ICP study. You all know it, 400 patients coordinated by Cambridge. The protocol for management is clear. ICP over 25, we do whatever we can for a medical treatment. Then if the ICP is not controlled, we randomize the patient between continuing medical treatment, including barbiturates, or surgery and decompression. The results, you see it here, you see on the left, the black side, double, almost double mortality in the medical group, almost double morbidity in the surgical group, and better good results in the surgical group, but not to a statistically significant degree. The outcomes are deeply changed. This is a complicated slide, but I made it easy. If you wait until 12 months and you treat the patient for a long time, then the result of the surgical group are better, both in the DECRA and in the rescue ICP. What does it mean? That treating the decompression by placing a cranioplasty or treating the associated hydrocephalus is helpful to improve the outcome of the patient. So we need a long treatment of these patients after decompression. And the guidelines after the publication of these two papers stated that we don't have evidence, strong evidence in favor or against decompression, but we have done, together with some Pakistan colleagues also, a consensus conference in Cambridge, and we have made some recommendation for decompression, especially in fields where we don't have class 1 studies like subdural hematomas. So the question now, the hot question is, do we have alternatives to decompression? One alternative is the hinge or floating craniotomy, which is raising the bone flap without taking it out. And this has been written from many countries. You see, this is Nigeria. It's a paper about the concept of what we call hinge craniotomy, raising up the bone flap. This is India, where they published the so-called oscutaneous bone flap, the bone flap linked to the muscle and raised up after decompression without taking it out. This is Brazil, different technique, cutting the bone and splitting it out to increase the volume. This is in China. You see the same concept, raising the bone with plates and screws and then coming back and putting the bone down. So the hinge craniectomy has an important future, but we also need to understand when it is indicated. We have evidence that is not worse than decompressive craniectomy, but we have no studies to confirm it. The other technique is the cystonotomy, with or without decompression. There is a full philosophy behind the cystonotomy. I make it easy. Opening the cistern is not only helpful to reduce intracranial pressure, but is also helpful to reduce the passage of CSF into the brain. You see it here. So everyone in the room where I've seen you are knows how to open a cistern, a basal cistern. We have many single cases papers, but we have only 2 papers with more than 5 cases, who are two papers, one from Europe, one from India, with 40 patients. This is a paper from Europe, from Lausanne, Switzerland, where they randomized 40 patients were randomized. They included retrospectively 40 patients, 18 with the decompression plus cystonotomy, 18 only with decompression. The ICP was better controlled in the cystonotomy group, as well as the outcomes were a bit better, but not significantly better in the group of patients with decompression plus cystonotomy. We wrote an editorial in the same paper, in the same issue of ACTA, but you know, this editorial revealed what is the status of cystonotomy. After we wrote the editorial, there have been many other papers about cystonotomy, and some of them cited only the paper by Giammattei without the editorial, and some of them cited only the editorial without the paper. So it means that in the community, there are two different religions. What is the limit of this paper? That the randomization was only done on the basis of the availability of a vascular surgeon to open the systems. So the patient is not randomized. If we have a vascular surgeon, we do the cystinotomy. If we don't have it, we don't do it. And obviously, this is an interesting technique. But again, as for hinge craniectomy, we need a very well done randomized study. This is the Indian paper, again, with 40 patients, same results with slightly better, slightly good outcomes in the group of cystinotomy. As you see, the limit is only one surgeon, one microvascular surgeon, and the outcomes are too good to understand that the indication were the same as for decompression. But again, the editorial from Professor Chandra, the editor of Neurological India, it's the same as before. We need more studies to settle down these queries. So we have a lot of limitation. You can read it here. It's difficult to retract a swollen temporal lobe. There is a learning curve. It may take time to complete the procedure of cystinotomy in a patient with a swelling post-traumatic brain. And again, we have to avoid injuries to vascular structure and optic nerves. So what we have to accept that science cannot jump. We need in surgical innovation that we are in favor of surgical innovation. We need a rigorous evaluation before to understand if it's working as a standard technique or not. But this, the website doesn't wait. And in the Facebook, in the Neurosurgical Cocktail, the largest forum for neurosurgery, you see that after this discussion, there was a lot of question about, do we need really neurosurgeon who write the books and papers, or we need only people who can operate nicely? And this is a wrong question. The neurosurgeon says our old Harvey Cushing keeps saying is a mixture between moving hands and brain. So we need to move our hands, but also to publish what we are doing. So we need to wait until we have good indication. And just to finish, I want to show you one case, how difficult it is to decide that this is a patient with a brainstem hematoma and large contusion, but only 15 years. The relatives were desperate, so we decided we could decompress the patient, and actually the follow-up was a misery with all possible complications, 11 surgeries, and he died after 6 years of persistent vegetative state. So what we have to think is not where we want to go, probably, but think about indication for decompression. Indication for any measure is an extreme measure. We cannot only decide on the basis of a medical indication, but also there is a social context, a context of the society who is able to treat the patient with a severe disability, many other considerations, and on the top, the need for very good studies. As we say in Latin, primum non nocere. So I thank you for your attention. I'm sorry to have disrupted your interesting hybrid, I will call, conference, and I hope to see you in person as soon as possible.